So it's my pleasure to introduce again Dr. Dangayach to the group. She is the co-director of the Neurosciences ICU at Mount Sinai Hospital and director of the NEMAT and critical care recovery programs. She began her training in Mumbai in India and continued her with a neurology residency at Case Western before completing her neurocritical care fellowship at the combined program at Columbia and Cornell, and a master's in clinical research here at Sinai before joining the faculty. She has won a number of awards and is going to talk to us today about several of the systems that have been developed here at Sinai for managing critical care triage and critical care recovery.
Thank you, Dr. Morgenstern, for that kind introduction. I'm just going to go ahead and share my slide. Just one moment, please. Okay. All right, and you see it in slideshow mode?
Yes,
awesome.
That's good.
All right. So several of you have heard talks on NEMAT before, and we're moving in some exciting directions. So this was a good time to share some updates with you. I have a few financial disclosures, but none of them are going to relate to the content that I'm going to present today. Our objective, of course, will do a quick recap of what NEMAT has been doing over the past few years, a few publications. I'll talk a little bit about critical care recovery, and then what are our future directions. So as I think about neuroemergencies and the empiric sort of phases of care, our patients need to be moved from one phase to another phase. And each of these phases, while they're needed to provide definitive care, they also pose some very specific vulnerabilities that could lead to fragmentation of care, loss of vital information, loss to follow-up, and lack of inadequate preparation even for our patients as they transition to this new state of normal. So similarly, when we think about empiric phases of care for all critically ill patients, they transition from this acute illness, the hospital recovery, early post-discharge recovery, so on and so forth. And each of these phases, as much as it presents certain vulnerabilities and challenges, also presents various opportunities. When you think about elective cases, these are patients who should leave the hospital healthier, if not as healthy as they were before they came to the hospital. So for those patients, again, there are these different phases of care that we can think about, from the outpatient phase when you see them in clinic, optimizing them for surgery, the OR phase, post-op recovery, so on and so forth. But today's presentation will focus more on the neuroemergencies and critically ill patients. I won't be talking more about our elective cases. So what are we trying to solve? What is the problem statement here? The problem is fragmentation of care. And when I look at literature for what is fragmentation of care, there is no standard agreed upon definition, but an operational definition that has become more applicable is this. It's a lack of continuity of care and care that is provided by disparate healthcare professionals without integration of clinical information. There are lots of problems here. Without integration of clinical information, patients presenting to different sites, patients presenting to hospitals that they did not get their index care at, so on and so forth. So that creates a lot of issues, particularly with higher cost of care, lower quality of care, worsened outcomes, higher readmissions, amongst others. So when we look at these phases of care, when we began thinking about NEMAT, the larger umbrella question that we're trying to answer, will consolidation of care into larger health systems improve this kind of fragmentation? We know that there's going to be an increase in interfacility transfers, just given this kind of care consolidation for definitive care. So is that going to improve access to care? Is it safe to transfer patients who are critically ill with different kinds of neuroemergencies? What do you need to do to make these transfers safer and to improve outcomes? So then we look at literature just overall for all critically ill patients. Which patients should be transferred? Is it safe to transfer critically ill patients? So the summary of what is available in literature currently, that was highlighted by the SCCM guideline statement in 2016, insufficient data to make a recommendation for or against ICU to ICU transfer. So what about neuroemergencies? So the bottom line is there's sparse data, there's conflicting data. Of a certain neuroemergencies, there's no data at all. So what does this mean? This essentially means that we are in a unique position to study interfacility transfer for different kinds of neuroemergencies. A paper that was published from Mount Sinai before Mount Sinai became a health system looked at SAH, ICH, subdural hematoma transfers and reported that there was no difference in outcomes for these patients who were transferred as opposed to patients who were admitted directly from the ED. When we look at the need for transfers, so why do patients with acute brain injuries need to be transferred? The obvious answer is for definitive expert care. The American Heart Association recommends transferring patients with hemorrhagic stroke to centers that are able to provide neurocritical care, neurosurgical, neuroendovascular care. So as part of a systems of care approach, patients may undergo transfers because of hub and spoke models. But how do we transfer patients with acute brain injuries such that you're continuing to manage their primary neurological injury, but preventing secondary neurological injury? So some critical care management needs to be started on site, whether it's airway, hemodynamics, raised ICP, coagulopathy, seizures, etc. But when we're doing this kind of work, what outcomes are meaningful to track? How do we ensure that there's closed loop communication? Those are some areas of study for us. When we look at the trends for transfers for thrombectomy, I'll focus a little bit on stroke because that's my area of research interests. So when we look at transfers, this paper was published from the nationwide inpatient sample that shows that the total number of thrombectomies year after year has been increasing. The total number of patients who are receiving TPA has been increasing, and so is the total number of interhospital transfers. So we did a similar paper looking at interhospital transfers for subarachnoid hemorrhage patients. And what we also saw was a similar trend of increasing transfers from about 30% to almost 40%. So if time is brain, how do we uphold this in a systems of care model? We know that the total number of transfers are going to continue to increase as care gets consolidated into health systems. When we look at the trauma systems of care and how trauma systems of care evolved, the number of papers that it took to impact the fact that trauma systems of care improve outcomes and make it a policy statement, there were several. It has taken several years for trauma to reach that stage. Similarly, stroke is moving in the same direction. So what about all other neuroemergencies? So when we look at stroke, this slide is from Dr. Marco. There is a problem. There's a transfer patient dilemma that even in an ideal scenario, we're going to lose some time. And if we're losing some time and we're saying time is brain, how do we overcome that problem? In a stroke systems of care model, we're a comprehensive stroke center. We have several thrombectomy capable sites within our health system. This publication from the American Heart Association tells us that only about half of the patients who are eligible for acute ischemic stroke interventional therapies or TPA are coming to the hospital via EMS. So there are obvious delays. That education is a problem. But that has not become a focus for us as NEMAT. Our role starts after a patient has been picked up by EMS. For Mount Sinai Health System, being a comprehensive stroke center, thrombectomy capable site with over 2,000 stroke discharges, we're in a very unique position to really capture the entire gamut of what stroke systems of care, what an ideal stroke systems of care can actually do to improve patient outcomes. So the current state of neurocritical care at Mount Sinai Health System, for all of you who are on the call, you're very familiar with the model that we've been working with since 2017. We do have components of critical care recovery as well as NEMAT, and that's what I'm going to focus on today. With NEMAT, specifically looking at the deployment of time-sensitive resources to the sites where patients present and concentrating resource-intensive treatments at specific sites. So this very much follows the philosophy that Dr. Bedison outlined for our department, from where these centers of excellence approach was born. In 2015, we started triaging our ICH patients over to Mount Sinai West with the development of this novel therapy at that time, SCUBA, minimally invasive clot evacuation. And similarly, we've been consolidating the care of subarachnoid hemorrhage patients, AVM patients at Mount Sinai Hospital, so on and so forth. So with that, when we think about NEMAT, what is our mission statement? To advance clinical care research and education for all neuroemergencies in a large urban health system. And for neuroemergencies, stroke, traumatic brain injury, patients with brain tumor emergencies. So how do you get the right patient to the right place at the right time, every single time, and create a system that can be replicated, not just for Mount Sinai, but for other parts of the country? For NEMAT, specifically looking at the different phases, the hyperacute phase to the acute phase to the integration back into life roles, it takes a village. It takes interdisciplinary collaboration throughout all of these different phases. And then the reintegration back into life roles, thus was born the Critical Care Recovery Program for providing continuity of care and for humanizing the ICU. So translating certain transfer levels into meaningful triage. Our health systems transfer policy was first published in 2018. And Dr. Bedison at that time had suggested maybe we can use how OR categories are time sensitive, and the definitions that we use for OR categories, maybe we can translate that into how we define transfer levels. So there is that sense of urgency when we're initiating some of these transfers. So thus we came up with certain empiric time limits for life rescue, departure from the referring site within 30 minutes, departure within 60 minutes for level 1, departure within 4 hours for level 2, and for level 3, we agreed that once a bed was available, we'd activate the transfer. So how did we translate that for NEMAT? We translated that for NEMAT. We thought perhaps all elbows should be regarded as life rescues. High-grade SAHs should be regarded as life rescues. Anybody who has ongoing herniation should be a life rescue. So when you look at the right-hand side of the slide, specifically looking at the median time to transfer for levels 1, 2, and life rescues, what I do want to draw your attention to is for life rescues, we have stayed at about just under 100 minutes for median time to transfer despite the pandemic. So bringing your attention back to why this is difficult and why it's needed, because patients are at a risk of developing secondary neurological injury. Patients are at a risk of dying if they do not receive definitive care in a timely fashion. So that has prompted us to develop this robust system. When we look at our median time for transfers for all neuroemergencies in the pre-NEMAT phase, it was 284 minutes. After NEMAT was instituted, so 2020's time was 132 minutes for all levels of transfer, despite the pandemic. And the crux of the program, how does the program run? So the referring hospital calls our command center or transfer center. There's a 3-way call, and these are our top 10 neuroemergencies. When you look at the right-hand side of this slide, specifically looking at our numbers, so since the inception of the program, we've been doing about 1,000 neuroemergencies every year, and the total number of cases. So we've been doing a lot of stroke triages, and stroke triages account for about a quarter of the patients that we transfer. The total number of subarachnoid hemorrhage patients has also remained more or less stable. We're a high volume subarachnoid hemorrhage center. We take care of a little over 100 subarachnoid hemorrhage patients every year. We take care of about 140 to 150 ICH patients every year. So the median transfer time for 2021 so far, we have ticked up a little. It's about 136 minutes. And I won't go into the specifics, but I do want to show you that there's a lot of room for improvement when you look at other neuroemergencies. For example, when we are drilling down into our brain tumors, a lot of our brain tumor emergencies are not levels 1, 2, or life rescue. Several of them are level 3s, and perhaps that's one of the reasons why it takes longer to bring them in, because it's limited on our ability to create a bed for a patient in a timely fashion. Our paradigm currently, and this is more for the residents on the call, on how the system is distributed. So for all the elbows go to the stroke triage fellow and the endovascular fellow. Hemorrhagic stroke, NEMAT is the first point of contact. We loop in the neurosurgery resident over at MSW, as well as the endovascular fellow. Status epilepticus goes to NEMAT, the epilepsy team, brain tumors. Depending upon whether it's a level 3 or life rescue, will either go to NEMAT or the triage resident. Trauma, we have been able to leverage a successful partnership with Mount Sinai Morningside, and the trauma pathway has become much smoother. And the total number of subdural hematomas, just as an example, pre-NEMAT involvement, there were about 25 cases that were sent to Mount Sinai Morningside. After NEMAT was involved, that number increased to 125. So do patients benefit from being transferred? What are these barriers? and which patients don't need to be transferred. The last question is perhaps one of the most difficult questions to answer. And as we collect more data, we'll be in a better position to answer that. So one of the questions that came up was, do IFTs differ for different strokes? If we're trying to uphold time is brain, then it doesn't matter what type of stroke we're dealing with. Patients should be transferred in the same amount of time. But what we have found, when you look at acute ischemic stroke, the blue bar is the time to initiation. The pink bar is the time to travel to the transferring hospital. The time at the transferring hospital, remember I was telling you about life rescue, leaving the transferring hospital or referring hospital within 30 minutes. So for our life rescue numbers, we are getting better. And then the travel time. There are some variables that are not in our control. For example, travel time. The travel time to the transferring hospital, as well as travel time to the accepting hospital, just based on New York City traffic. So when you look at transfer times for ICH and how much time patients are spending at the transferring hospital, it's much more than acute ischemic stroke patients. And it makes you wonder, why is there that difference? And similarly for SAH as well, we're seeing more time spent at the transferring hospital. So we're really not meeting that empiric time metric of transferring patients within 30 minutes of their EMS crew reaching the site to pick them up. And why is that happening? So our hypothesis is this is probably happening because patients with hemorrhagic stroke require a little more stabilization. Perhaps they need their airway secured, their blood pressure needs to be managed more, or they need some reversal products which are not as readily available, for example, as TPA or TNK for acute ischemic stroke patients. Did COVID-19 impact transfer times for NEMAT? So a quick look at the transfer times. So we looked at the time period for the first wave and compared it. So January through March 14th and March 15th through April 30th, comparing it from 2019, 2020, and from 2018 through 2020. And what we found was the total number of patients remained more or less the same. And the transfer time, specifically the transfer time for life rescues, also did not increase. Can we predict based on triage characteristics? So once a patient is transferred and they come, or a patient is presented, presents via EMS and comes to the ED, just based on their initial 30 minutes of arrival to the ED, can we predict they're going to need an NSICU bed? This question was prompted by the fact that every time we transfer patients, sometimes it is not the availability of the teams that need to take care of these patients. It's not the availabilities of the ORs or the endovascular suites. It's literally the bed availability. So if we're able to shave off minutes, if we're able to get the processes for creating beds initiated much faster, we should be able to uphold time is brain, and beds may no longer be that sort of resource limitation. So that's what prompted this question. And we used a machine learning approach to try to answer this question. So within the first 30 minutes of presenting, looking at structured as well as unstructured data, triage notes, the emergency severity index, and vitals, we created a model. And essentially, this included a little over 400,000 patients. Of those 400,000 patients, 84,500 patients or so were hospitalized. And of those, about 1,900 patients had required NSICU admissions. And the most important thing in the predictive sort of tabular-free text machine learning approach turned out to be the chief complaint as well as the ESI. And if the word stroke or CT were included in the triage note, then it predicted the need for an NSICU bed. When you look at the model, so both for the text data as well as the structured data, but when we combine text and structured data, our ability to predict who's going to need an NSICU bed based on the first 30 minutes of their triage characteristics was about 93%. All of you are aware of these endovascular trials that have made the gold standard of treatment for emergent large vessel occlusion, thrombectomy. And we know that the number needed to treat to improve functional outcomes is only about 3 to 4. So all of these trials had required, why did this happen in 2015? This happened because all of these trials had required a vascular diagnosis. And these trials, all the patients were treated much faster, and making sure that we adapt our health system in light of emerging evidence. So this was one of the earliest papers that Justin Massatelli put together after the first few randomized controlled clinical trials in 2015, showing how we as a health system changed. We changed because we changed our process. We changed that we don't need to wait for creatinine. So radiology, and our ED colleagues agreed that, okay, we're not going to wait for creatinine, and CVA is equal to CTA for our health system. And for ELVO, inter-hospital transfer, or inter-facility transfer, we're going to do ER to ER transfers for some of our sites, and that's going to save time to recanalization. So going back to beds can be a rate limiting factor, but we don't want that to be a rate limiting factor. This ER to ER paradigm has helped us shave off a few more minutes. And parallel processing. And the biggest thing that came out of the evolution of our health system in line with literature was this impressive change of interdisciplinary effort between multidisciplinary team members to uphold time is brain. Do all patients who have a suspected ELVO need to be transferred? Dr. Joanna Fifi is the PI for our NYC MIST model, and it's a very innovative model that has looked at a mobile interventional stroke team. It's a model that does not necessarily exist in the way it exists at Mount Sinai. And two landmark studies from the NYC MIST model. So specifically looking at how a mobile interventional stroke team can help shave off time and potentially improve outcomes. So the case paradigm, one of the first cases that was that experienced the NYC MIST was this 92-year-old, and this was a while ago, and real-time feedback was provided. And for this patient who underwent thrombectomy at Mount Sinai Queens, she ended up having not a straightforward lesion. She had both a basilar as well as a right MCA. So this patient, after undergoing their thrombectomy, was transferred over to Mount Sinai Hospital. For the NYC MIST model, the initial door to recanalization time has also remained faster for trip and treat. And when you look at specifically all of these different models, without going into the specifics, I just want to draw your attention to the types of models. So the square in the center is our comprehensive stroke center. And everywhere where you see this white arrow specifically refers to how the mobile interventional stroke team goes out from our comprehensive stroke center to multiple sites. So the hypothesis here was that the delivery of care by MIST to patients is going to be more time efficient. It's going to lead to improved outcomes as compared to a drip and ship model, and it's going to be comparable to patients who are presenting directly to comprehensive stroke centers. And when you look at the different times, so the first gray bar that you see is contact to initial door, and then how much time are patients spending, the door in, door out time, which is going to become an important metric as we begin to look at some of this interfacility or inter-hospital transfer literature, the DIDO, or door in, door out time. So how much time are patients spending and how much time is the transfer itself taking? And then the door to puncture time, which is another key metric. So as you can see, for the NYC MIST model, the overall recanalization time has definitely become much shorter. And there is, with respect to clinical outcomes, when we look at modified Rankin, the overall, there is a trend to improving functional outcomes in the NYC MIST model, as well as in the drip and ship MIST model. So if you identify that a patient with suspected ELVO should be transferred, do all patients who undergo transfers undergo thrombectomy after they're transferred? So this led to another paper with, again, with Dr. Fifi's team, and specifically looking at how many patients who, after undergoing transfers, did not undergo thrombectomy. So about 40% or so patients who undergo inter-hospital transfers don't end up undergoing thrombectomies. In literature, this rate has been reported to be as high as 54% as well. So why does that happen? That happens because some patients may complete their stroke while they're undergoing inter-hospital transfers. A third of the patients completed their strokes, or they may have no ELVO, or their ELVO may have been gotten spontaneously recanalized or recanalized because of TPA or TNK. In this study, we did not include patients who had undergone who had received TNK, only TPA. Or the patients may have really mild or clinically improving symptoms. But there were also other causes post TPA hemorrhage. patients presenting outside the treatment window, for patients who did not have a proven elbow. So at our primary stroke centers or hospitals that we're picking these patients up from, if they don't undergo a vessel imaging or high quality vessel imaging in a timely fashion, we're sometimes bypassing that imaging and getting that imaging when these patients arrive at either a thrombectomy capable site or at our comprehensive stroke center. So potential solutions would be to improve imaging capabilities at primary stroke centers or and providing overall improving how our time to transfer or how much time is being spent at these sites once a transfer has been activated to continue to improve access to thrombectomy. For hemorrhagic stroke, now just shifting gears from ischemic stroke to hemorrhagic stroke, I did specify a few slides ago that these patients may be sicker. More of these patients may require their airway to be managed and coagulopathy reversal to be given prior to their transfers. So we came up with our own protocols, and this is for the residents and fellows on the call. We do have checklists for how you can learn how to triage patients. What pieces of information do you need? How do you stabilize these patients to prevent secondary neurological injury? As you're parallel processing, you deploy the ambulance and you also provide all of this information to the frontline staff to start securing their airway, controlling their blood pressure, coagulopathy reversal, seizure prevention, so on and so forth. So let's talk about a subarachnoid hemorrhage patient and take a pause and think about what you would do. The patient is a 38-year-old female. She's unresponsive. She's found by her friend, and she gets intubated by EMS and goes to Mount Sinai Morningside. Her pupils are reactive. She's withdrawing all extremities, and her CT head shows acute hydrocephalus and a modified Fisher-4 subarachnoid hemorrhage. Neurosurgery is consulted, and this patient is over at Mount Sinai Morningside. Take a little pause and think about what you would do. And for the residents, if you want to unmute and let me know what you would do. Brandon or Noah?
Brandon, what would you do?
Yeah, I think that the first thing I would want to do is at least get the patient stabilized at the outside hospital. She would likely require an EVD to stabilize the patient there, and then you'd want to look to transfer the patient once stabilized to within our system, MSH, for the subarachnoid center.
Mm-hmm. So you would want the EVD placed at Mount Sinai Morningside because we have our neurosurgery team. But even if this was another hospital that was referring such a patient to us, that's not part of our health system, also requesting for our neurosurgery, for the neurosurgery team at the referring hospital to place an EVD as we are activating all resources to bring the patient over to us. And you're going to institute ICP management. So this is what the patient scan look like. Thanks, Brandon. This is what the patient scan look like. And so patient gets their EVD at Mount Sinai Morningside. And what instructions would you give, Noah? So the patients receive their EVD and now needs to be transferred over to Mount Sinai Hospital. What instructions would you give to the EMS crew?
So typical subarachnoid management, so keep their blood pressure under 140. For the ride over to the hospital, probably tell them to clamp the EVD so we don't overdrain the patient. Frequent pupil checks, mannitol as needed.
Okay, that's very good. The key point about whether the EVD should be clamped or whether the EVD should be left open, we know that this patient has raised intracranial pressure. We know that this patient has obstructive hydrocephalus. And one of the things that we discovered as we started doing these inter-hospital transfers after placement of EVD, not a lot of hospitals across the country are actually doing this. So there are no protocols for how do you transfer a patient with an EVD, and EMS crews are not taught that. So we internally did come up with a protocol, and I'll show you some data from that. When this patient arrived to Mount Sinai Hospital, Their left pupil that was initially 3 millimeters, minimally reactive, then became 4 millimeters, stopped reacting. Patient essentially herniated and had a systolic blood pressure of 170. Now, despite giving the instructions for maintaining systolic blood pressures of less than 140, why did this patient arrive with a blood pressure that was high? Why did this patient herniate? So we treat her, she gets mannitol 23.4%, and long story short, her herniation was a reversible process. So all herniation is not created the same. Timely access to therapy, timely access to definitive CSF diversion or decompression is going to reverse that process. And the patient was extubated on post-bleed day 2. So we as part of our NEMAT subarachnoid hemorrhage protocol, we've created some specifics on how we should be instituting this care. For the inter-hospital transfers for patients who have EVDs, this is a protocol that we're continuing to collect data for. For patients who receive EVD at a hospital like Elmhurst or Mount Sinai Morningside that have the capabilities of placing EVDs, we are clamping them for transport. But because we're clamping them for transport, we're pre-treating these patients with 1 gram of mannitol, or we would request if the ride is going to be more than an hour long, then an additional dose of mannitol. And I'll show you some preliminary data from this. So for about 15 patients, none of the patients who underwent this protocol, so it included both SAH and ICH patients, none of the patients presented with an ICP of greater than 20. So there were no herniation events after instituting this protocol for patients who underwent inter-hospital transfer with EVD. For ICH, so shifting gears to ICH, guidelines recommend that patients should be admitted quickly to stroke units or to neuro ICUs. And there's a lot of variability in how ICH specific protocols are followed at different sites despite high quality evidence. And better outcomes have been reported for ICH patients who are managed in neuro ICUs. And some of these slides are courtesy Dr. Christopher Kellner, our director for the ICH program. Should we remove blood? How should we remove it? And when should we remove it? And he's published, his publications highlight clearly that there is a need to evacuate ICH. And when we compare MISTI to Mount Sinai's patients who were eligible for clot evacuation, essentially, the better the clot evacuation, the better the likelihood of outcomes. And in a more recent publication, we also showed that the time to evacuation matters. So upholding time is brain for ICH matters. In this systematic review, again, that minimally invasive clot evacuation improves outcomes. So we described our experience with NEMAT and SCUBA. We know that we've been cohorting the care of ICH patients at Mount Sinai West since 2015. So in this first publication, we included 100 patients, 89 of whom who had undergone inter-hospital transfers, and we had 11 direct admits who underwent SCUBA. What we found was there was no difference in functional outcomes for patients who had been directly admitted versus those who had been transferred. However, I should point out that the primary purpose of this study was not to compare ED admits to inter-hospital transfer patients. We just wanted to specifically see whether transferring patients worsens their outcomes or not. And we're going to continue collecting data to specifically answer this question. Is there a difference between patients who come directly via the ED versus those that get transferred? And looking at the transfer data, we did, just given where our patients are coming from, irrespective of the transfer distance, the outcomes were not different. So various protocols and checklists, a lot of these will be published online in due course of time. We've been educating, these pictures are all pre-COVID, that's why you don't see masks, but we have been educating various team members, including our transfer center, going out to different sites. So Dr. Reed DeLacy at Brooklyn Hospital. So we've been going out to different sites to educate our collaborators about our process, as well as how to improve patient outcomes and reduce times, how to recognize who needs to be transferred, what therapies to institute when we're transferring and triaging neuro emergencies, and minimizing the time at the referring hospital to improve our ability to uphold time is brain. For our nursing colleagues, we did, I see Tanvir has raised his hand. Tanvir, you want to go ahead and unmute? Tanvir, feel free to unmute and ask any questions. I see something in the chat as well. Okay, got it. We need to make you panelist. Okay. Peter, are you able to do that?
Hi, good morning. Can you hear me?
Oh, perfect. Thank you. Yes.
Okay, thank you. I just wanted to, on this topic of the roadshow and education, I wanted to just highlight one aspect. First of all, thank you for the presentation and the great NEMAT program. The spine team has felt a lack of precision on the exams at these outside centers, even sometimes our own centers, where we've had patients even from Beth Israel, which have been billed as totally plegic and are basically fine. And we've seen it in the last year, the reverse, where patients are billed as fine and they're totally plegic. And, you know, I don't know all the factors on this, but I would like to encourage us all, and maybe we'll have to play a role as spine faculty in doing some on-site visits to see if we can help tighten that up. And I don't, there's a lot of people involved. Maybe we'll have to do some video visits, but do you have any thoughts on the exams at these outside places, which are quite important for certain diagnoses? Thank you.
Oh, that is such an excellent point. And that holds true, Tanvir, also for all the other neuroemergencies. We're taking the exams that are being provided to us with a grain of salt, because the people who are reaching out to us are obviously calling us for help. And how much are they able to, how accurate are their exams going to be, and how frequently are they actually able to assess patients as patients are deteriorating? It's completely possible that the first exam that they performed was the exam that they're relaying to you, but by a lot of time has passed from their initial assessment, but they haven't had the opportunity to go and reassess the patient. So there is certainly that issue. There's certainly an issue with respect to knowledge and experience. Our ED colleagues are phenomenal, and they see so many different types of patients. So it is our duty and responsibility to educate them periodically. The Department of Neurology performs these grand rounds every few weeks with the ED department at Mount Sinai, for the Mount Sinai Health System. They specifically pick topics and go over specific neuroemergencies and discuss the specific neurological diagnoses, I should say, and provide education. So that could perhaps be an opportunity for us to think about, and then to go out to different sites. Of course, with COVID restrictions becoming a little bit less restricted, we may have the ability to reinstitute some of these either in a hybrid format or on site, but it's an absolutely worthwhile endeavor looking into. Thank you for that comment.
Thank you. We're happy to help.
Thank you. And just a quick segue into our what we've been doing for our nursing colleagues and emergency neurological life support. These are I'm part of developing these modules, so that's perhaps a conflict of interest, I should state. But specifically, this is developed by the Neurocritical Care Society and includes the top. It has about 13, 14 modules with evidence-based information about what to do in the first few hours of a neurological emergency. So irrespective of your background and how much you know about neurological and neurosurgical emergencies, ENLS is something that has become quite popular across the country and in different parts of the world now. So we used ENLS for educating about 400 nurses, and we did do a pre-survey, and right now we're in the process of looking at the post-ENLS survey responses from MICU, SICU, TICU, etc. nurses. The idea, the reason why this project was instituted, because patients are boarding in other ICUs due to a lack of neuro ICU beds, also helping our colleagues from other ICUs recognize neuro emergencies in a timely fashion so we can intervene upon them to uphold time as brain. Now, shifting gears from emergencies towards the post-acute care phase or the recovery phase. We've got to remember that there's a person behind the patient. ICUs can be very dehumanizing. And how do we uphold that person behind the patient as we take care of them is what makes the difference between a good and a poor outcome and a patient-centered outcome. So just summarizing, and I've spoken about ICU liberation post-intensive care syndrome before as part of neurocritical care pearls. Just summarizing this as part of the COVID-19 CHEST task force, we put together this infographic. So what is PICS? PICS is essentially unintended consequences of critical care in different domains, in the physical, cognitive, mental health, or psychiatric domain. And there are several risk factors that predispose our patients. All of the literature so far that has guided our understanding of PICS has not included patients with acute brain injuries, because it's very difficult to tease out what of these impairments are coming from acute brain injuries and which of these impairments are coming from just the exposure to the ICU, severity of the underlying critical illness. So most of the PICS literature at the present time excludes patients who've had acute brain injuries. And there are lots of ways of preventing and treating PICS: implementation of the A to F bundle or the ICU liberation bundle, critical care recovery programs, peer-to-peer support groups. It obviously takes a village both in as well as outside the ICU, and preparing patients for that new state of normal, preparing patients and their families for that new state of normal requires tremendous help and support. So we're part of two collaboratives. Initially, we were a part of the Society of Critical Care Medicine's Thrive Collaborative, and now we're a part of the Cairo Collaborative, which is a network of post-ICU recovery clinics and peer-to-peer support groups for critically ill patients. And throughout the different aspects of recovery, there are lots of different opportunities, whether it's with respect to pharmacy, with medical equipment, subspecialty medical care. So in our critical care recovery clinic, when we see patients, we're seeing patients, so the intensive, it's a multi-ICU clinic, but the neuro ICU patients, I'm predominantly seeing the neuro ICU patients with our neurocritical care pharmacist, and then we refer patients to spiritual care, social work, subspecialty care, get them PCPs, so on and so forth. This is what typical contemporary critical care recovery programs are looking like. And we've at least instituted, it's taken us a few years but to develop this, but we've been able to institute at least two aspects of the program, as well as start a pilot for ICU diaries in our ICU. So early mobilization, there's a lot of literature on this. And I point you to this ICU mobilization network if you're interested in it. For the critical care recovery program, again, this is also a pre-COVID picture. No masks. There are several projects that we've undertaken. We have key collaborations with the spiritual care department and a collaboration with the precision recovery program as well. For post-ICU recovery clinics, while they sound like a good idea, do they make a difference? In a recent systematic review that included 15 randomized controlled clinical trials, it found that critical care recovery clinics can reduce depression as well as anxiety, both for patients, and also improve medical management. So our first patients that we saw were in February of 2020. We had to very quickly pivot to a telehealth model. And the telehealth model is also a multidisciplinary model. And we described our experience specifically for our COVID-19 survivors. This was one of the first studies that described PICS in COVID-19 survivors. About 90% of the patients that we saw suffered from post-intensive care syndrome. Can we describe post-intensive care syndrome in patients with acute brain injuries? So in our attempt to describe neuro-PICS or NPICS, PICS in patients with acute brain injuries, this paper is a collaborative effort with the University of Cincinnati. We looked at a little over 1,100 stroke patients who were admitted to the neuro ICU, included ischemic and hemorrhagic stroke patients. And we described NPICS as being PICS with impairment at least in one domain. And what we found for these patients, about 40% of the patients at the time of follow-up at 4 months had died. And the patients who were able to give us telephonic outcome measures in different domains, 244 were diagnosed as having PICS. And patients who had impairments in more than 2 domains had worse quality of life. So from NEMAT to CCRP, I'm going to share a case with you that several of you may already be aware of. Megan Onofre, who had no previous medical problems. She developed a birth dissection basilar occlusion, presented to Mount Sinai Morningside, and was transferred over in under 100 minutes to Mount Sinai Hospital, underwent her thrombectomy. During her ICU stay, had several complications, had also required decompressions of suboccipital crani, EVD, VP shunt, ventriculitis, seizures, so on and so forth. Despite all of that, when we saw her in our critical care recovery clinic, she rated her frailty as 7. This is the clinical frailty scale is very much like an eyeball test of what frailty as a construct can mean. So she regarded herself as severely frail, but on this Connor-Davidson resilience scale, she rated her resilience as 47. To put this into context, the average American adult's resilience is about 34. So she described herself as being very resilient, but frail. So for Megan, who's been reintegrated back into society with her family, with her kids, and periodically the neuro ICU team receives updates from Megan's family, there are two big takeaways from her stroke. It can happen to anybody, including somebody who's very healthy. The stroke journey is a long one. It takes a while. I'm pushing myself very hard, and it's still taking a long time. So what are the future directions for NEMAT? I'm going to talk a little bit about our NEMAT Big Data Initiative and understanding how these different constructs, resilience, frailty, spirituality, impact outcomes, and implementation science aspects of our care delivery models and dashboard utilization with our Big Data Initiative. So our current approach, summarizing it, what we've essentially been doing is manual data entry. We're not collecting waveforms. We're only looking at discrete data that's collected retrospectively. It takes months to complete the database from a quality assurance perspective, let alone impact clinical care in real time. Each patient can have up to 13,000 fields. It's a massive data collection effort, which obviously translates into lots of missing data and inability to provide real-time guidance for improving patient outcomes. So for NEMAT 2.0, this is part of our NEMAT Big Data Initiative. We have several projects under transitions of care, so patients moving from one phase of care to another. Then for physiological data, imaging projects, natural language processing projects. Under the Transition of Care project, a project that was just recently funded by the Aneurysm and AVM Foundation is our subarachnoid hemorrhage project for creating dashboards and real-time dashboards for guiding subarachnoid hemorrhage care. A smart ambulance project that is a key collaboration with the departments of neurosurgery and rehabilitation. We're looking at a proof of concept for stroke. Subarachnoid hemorrhage patient family dyad project, which is a collaboration with Mount Sinai IP, Telehealth, and we're specifically looking at how to improve the education for patients and families about these different phases of care and deploying real-time education using a specialized platform. Physiological data, several of you have been hearing about Moberg for years, and we're finally moving towards that phase of deploying this in our Mount Sinai Hospital Neuro ICU. So collecting all of that data and analyzing it for predictive analytics. We did have a project that was funded by the FBI, the Friedman Brain Institute, right before COVID. So we really haven't been able to take that project forward. That project was a collaboration with the neuroscientists and with Eric Orman, who's now at NYU, specifically looking at high frequency data to predict low frequency outcomes using a mathematical model called State Tracker. We're currently working with NeuroSteer. It's a single electrode based EEG device to study how sedation can be titrated in ICU patients. For imaging projects, we have an exciting project where we're looking at DCI prediction with the clinical data science team. We've just received funding for creating a biophilic environment. This funding came from the Cullman family. This is also a collaboration with the Department of Rehabilitation and Studio Elsewhere. This entire big data initiative, Ben Rappaport from Sinai Biodesign, Arash Kia from Clinical Data Science, and and the Department of Neurosurgery. We're working very closely together to develop some of these innovative projects and to take them forward. One of our first publications that I shared with you was the NLP project, the ER triage paper. We're now looking at automated information extraction, trying to use NLP and create certain models using notes and text classifiers to understand disparities in care. How do we make all of this happen? So one of the key steps, leveraging the resources that are already existing, the clinical data science team has been very facile in putting together a complex data integrated platform, taking data streams from all these different data producers. The novelty for how we're going to collaborate with them, we're going to add data streams from EMS as well as data streams from wearables. And without going into the specifics, because I'm not the right person to talk about the specifics of how these databases will be created, but we're going to essentially use waveforms, imaging, wearables, EMS data streams, in addition to all the data streams that are already available to create machine learning applications to impact patient care. The NEMAT registry, the hope is with this approach, the NEMAT registry will become a live registry, and we're going to be able to provide clinical decision support. As proof of concept, the first disease process that we're looking to do this for is SAH, followed by ICH. So just a prototype snapshot of what some of these databases, what some of these dashboards, I apologize, could look like. A real-time dashboard, for example, the information within the body of Epic could look something like this. You get information about a patient who needs to be transferred. You get this time alert embedded within Epic. It shows you EMS ETA is about 15 minutes. Blood pressure wasn't well controlled and now is better controlled. Coagulopathy has been reversed. But then there's another patient who there's a delay in providing care. And you as the expert who's triaging this patient can then notify that frontline provider, hey, could you please take care of these things? And then a patient level or center level dashboard that can help us understand how our patients are doing. And we can use this as part of our conversations with various key stakeholders, but particularly patients and families. We're also collaborating with Chris Keller and David Petrino's Precision Recovery Program, and we're hoping that this collaboration can help create a patient-centered safety net. So I do want to leave some time for questions and want to thank particularly our patients and families and all our collaborators and all my mentors. This is the reason why we're doing what we're doing. And I'm going to leave the acknowledgement slide up because there's a lot of people to acknowledge. And our work has only just started. Thank you.
Thank you, Neha. It's a tour de force of a presentation. I'm sure that I hope that your colleagues and the residents who are hearing this and others recognize the depth of this presentation and the grand sweep of your vision. I think that you are already changing the way we deliver care to patients with neurological illness. I know that's the case. So what do you think is the most exciting thing that you're doing of the 25 different projects that we heard a taste of? What's the one that today is giving you the most excitement and joy to participate in?
I think the most exciting thing for me, and I've been dreaming about this, is this integration of all the different streams of data to provide real-time information for improving the care for hemorrhagic stroke patients. I think that systems of care model for acute ischemic stroke patients has definitely improved quite a bit. But when I look at literature for hemorrhagic stroke patients, our ICH and SAH patients, I think there is a need, and we can have a big impact on how these patients are getting care. There always is this, there's a huge body of literature on self-fulfilling prophecies for these patients. When they present to different hospitals, DNR gets instituted and these patients could potentially have a higher mortality just because of a self-fulfilling prophecy. What I'm hoping our work can do is inform the frontline providers that there's hope and these patients deserve to be transferred in a timely fashion for definitive care. And with Chris Kellner and team working on SCUBA, creating a treatment that is time sensitive, that wasn't available for ICH patients just a few years ago, I think we can change the care paradigm completely. So that's the thing that I'm most excited about.
Yeah. And then also to know who does not need to be transferred, because no matter what you do, they're just not going to make it. I think that's important as well, to shepherd our resources properly.